Female genital mutilation in Somalia. 230 million women alive today have undergone female genital mutilation. Female genital mutilation, shortened FGM, is the partial or complete removal of external female genitalia for non-medical reasons. There are 4 types of FGM. Type 1 is the partial or total removal of the clitoris with or without the removal of the clitoral hood. Type 2 is the partial or total removal of the clitoris and the labia minora with or without the removal of the labia majora. Type 3, infibulation, is the narrowing of the vaginal opening and the creation of a covering seal formed from the labias and can be with or without the removal of the clitoris. Type 4 is all other harmful non-medical procedures done to female genitalia. In Somalia, 99.2% of women ages 15 to 49 have undergone FGM, with the majority having undergone Type 3. A study in Somalia found that 90% of women who have undergone FGM experienced health problems and birth difficulties such as infertility, vaginal fistula, and maternal and neonatal fatality. Female genital mutilation is a clear violation of human and women's rights. It violates a person's rights to health, security, physical integrity, freedom from cruel treatment and torture, and in some cases the right to life.
In Somalia, deeply ingrained beliefs about purity, virginity, and female sexuality are used to justify these practices. For families to be accepted, their daughters must undergo female genital mutilation, or else they may be rejected from their community. Female genital mutilation is believed to prepare daughters for marriage and adulthood by preserving their premarital virginity, which protects the family's honor. Additionally, these procedures are conducted for aesthetic and hygienic reasons. Women who undergo female genital mutilation are therefore more likely to have better marriage prospects, which has the potential of bringing financial and social gains to their families. Thus, this incentivizes parents to have their daughters undergo this procedure. Additionally, 72.1% of women in Somalia have undergone female genital mutilation because they believed Islam required it and therefore it made them better Muslims. Female genital mutilation is also a mainstream of income for circumcisers. Considering these social, cultural, and economic factors, these procedures are so ingrained in the culture in Somalia that it is difficult to enact change.
Women have historically been oppressed, and female genital mutilation fundamentally takes away a woman's control, making it not only a public health issue but a human rights one too. As many of these women are children at the time, no child is capable of giving consent nor truly understanding the atrocious side effects that come with it. While men have circumcision, this practice comes nowhere close to FGM, and the two are not even comparable, since one is a harmless procedure and the other is mutilation that targets women. With an intersectional approach, it can be shown that there are more coupled identities that can be more impacted by this issue. The intersection of gender and education significantly impacts the occurrence of FGM. In fact, a Turkish hospital performed a cross-sectional observational study on Somali women in FGM and found a statistically significant association between the type of FGM one gets and the level of education. Less educated women are more likely to get the most harmful and extreme form of FGM, infibulation. Another study found that increased maternal education and literacy decreased the likelihood of FGM among daughters. A more educated woman is less likely to be supportive of FGM. Ideally, it seems that by increasing women's access to education can help address this. It must be noted that only 25% of girls in Somalia formerly go to school, which helps perpetuate this cycle of oppression. In Somalia, the education sector only receives 12% of funding, which enforces the difficulty of getting an education. Another aspect that plays a role in FGM is the location of these women. A study in Somalia found that daughters of women in urban areas were 70% less likely to undergo FGM. Lastly, another intersection of identity is religion. Many Somali women identify as Muslim, many of whom want to remain chaste until marriage. This contributes to societal pressure to have their bodies mutilated to follow this. Female genital mutilation in Somalia remains to be a critical discriminatory public health crisis that puts women of all ages at major risk. Its high prevalence needs to be noted and taken into consideration by larger powers. FGM mirrors entrenched cultural and social practices that reinforces gender inequality and is a complete violation of women's rights. In order to properly address FGM, a multifaceted, women-centered approach needs to be implemented. This culturally appropriate approach will consider the intersection of the following social determinants of health, gender, education, and location. Methods to dismantle the societal structures that condone FGM must include education of the public, legal reform, and community engagement. Actors that will play a major role consist of the government, local organizations, communities, and religious leaders. A continued dialogue with religious leaders and community members will help to gain support in order to discourage and ultimately ban the currently widespread practice of FGM. This requires knowledge and insight of the Quran and the Islamic religion. It's also important to create community interventions about FGM's possible consequences, and the need to dismantle it, particularly through involving men to bring about the desired change as a reflection of the local community. We need to ensure the health and safety of girls and women in Somalia.